Hello, everybody, and thank you so much for joining this event, Leveraging Digital Health to Drive Equity and Integration in Primary Care. This is one of 4 events that the Industry Initiatives team at Blue Shield of California is hosting in 2023. So please sign up for our newsletter if you haven't yet to make sure you catch the rest of our events for this year. Our focus today is on the opportunity to advance integrated and equitable primary care through digital solutions. The discussion will aim to balance the promise of virtual care. So, how we achieve virtual care's ambitious, but in many respects still unrealized outcomes against the current reality and the constraints of what is an inequitable system. We will focus particularly on access and equity for populations that are often overlooked. So really thinking about people, like people living with disabilities, those in rural areas, and queer communities. And might I add, it's June, so happy Pride Month to everybody. We have Gabriela Barbosa from the Children's Partnership, Dr. Brian Knox from Included Health, Dr. Yumi Taylor from Terra at Sutter Health, and finally, we have our very own Krishna Ramachandran from Blue Shield of California. I will have the panelists introduce themselves momentarily, but first I want to invite each of you to think about your role in this discussion today. So, all of you can engage in and contribute in some way to system changes that facilitate adoption and advancement of digital solutions in a way that really helps us achieve our collective goals on equitable and integrated care. Okay, so now I'm going to ask our panelists to come on camera. And okay, there we are. I see everybody. I'm going to ask each of you to give an overview of yourselves and how sort of digital health and systems innovation writ large fit within your work. So Brian, let's start with you.
Hi, everybody. Happy to be here. My name is Brian Knox, and I am a physician with Included Health. My clinical background has been in primary care, and I'm certified in both internal medicine and pediatrics. My work with Included Health, I'm one of the medical directors, so I help lead our clinical navigation team, assisting members get the right care when they need it, and also serve as one of the virtual primary care providers in our virtual practice as well. Happy to be here.
Great, thanks, Brian. Krishna.
Good to be here. Hi all, Krishna Ramachandran, Senior Vice President of Health Transformation and Provider Adoption at Blue Shield of California. I'm a new addition to the Blue Shield team. Good to be here and sort of kick off Pride Month with you all. In my role, I sort of partner with providers, stakeholders, other innovators to sort of reimagine the healthcare system. So I'm excited for the work ahead. Prior to Blue Shield, I was in another paid organization, Blue Cross Blue Shield of Illinois. And then before that, I was at a provider organization. And then prior to that, I was at a tech organization, Epic, which is a leading healthcare provider technology company in the United States. Good to be here.
Great, Krishna. And welcome to Blue Shield.
Thank you.
Of course. Yumi, want to go next?
Yes, thank you. Happy Pride Month, everyone. Hello, my name is Dr. Yumi Taylor. I'm a practicing physician entrepreneur. My background's in internal medicine and clinical informatics. I've been in healthcare for 20 years. The last 5 years, our team built Terra, a virtual first team-based primary care product for Sutter Health, a large integrated healthcare delivery system here in Northern California. Terra is described by healthcare leaders as way ahead of the curve. Our team is proud of hitting the holy grail in value-based care. We knocked it out of the park with 23 to 35% risk-adjusted total cost of care savings over the last 4 years. What I'm most proud of, though, is to hear the clinical care team share stories of how impactful their relationships are with patients because of our model design. They can right-size their care. They place patients on autopilot and spend less time with engaged patients, but on the flip side, spend more time relationship building and doing proactive outreach for unengaged patients, which I think sets an excellent scaffolding for addressing health inequity in overlooked populations. So I look forward to sharing more about that today. Thanks.
Thanks so much, Yumi. Gabriela, take us home.
Thanks, Joe. Thank you so much for inviting me to be part of this panel. My name is Gabriela Barbosa. I am the Managing Director of Policy at an organization called the Children's Partnership. I'm also a former teacher, lawyer, and most importantly, I have dedicated my life and my advocacy to ensuring that all children and youth in California have what they need to be healthy and succeed in life. A little bit about the Children's Partnership. We are a statewide children's advocacy organization dedicated to advancing health equity and racial justice for California's children from historically marginalized communities. We do this work through public policy advocacy, community research, and community education and engagement. And in order to achieve health equity for California's children, our work doesn't only focus on ensuring that all children have access to health coverage and care, but also on addressing the conditions that surround a child's life, where they live, learn, develop, and play. And those conditions shape their experiences and their ability to succeed and thrive and be healthy. So these conditions include addressing poverty, but also include addressing the lack of technology that children and families don't have in California, and essentially achieving digital equity. And digital equity refers to the condition in which all children have the information technology, the capacity, the education, the devices that they need for full participation in our society and our economy. And digital equity is important to us for achieving child health equity because we know that the systems that serve children and families that are crucial to their well-being are increasingly dependent upon digital infrastructure, including schools and learning, doctor visits and healthcare services, skills training, housing, job applications, and workforce development. So I'm really excited to be part of this conversation and talk more about our work.
Thank you all so much. I have to say, I'm just absolutely thrilled to have this variety of expertise on the panel, right? Like innovation ecosystem, a health plan, a provider organization, children's advocacy. I mean, it's like we have the holy grail of expertise right here. And I'm just so thankful to you all for being here today. And I know I speak for myself and my team and the audience when I express my appreciation to all of you. So let's get started with the first question. Okay, how can digital care, digital primary care in particular, be used to increase access and equity, especially for those specific populations I mentioned earlier? So focusing in on people with disabilities, those living in rural or remote areas, as well as queer communities. Yumi, let's start with you.
Great, thanks, Joe. So as context, as I mentioned before, where we've learned, Terra's learned is in a capitated population embedded within Sutter, which is this, large integrated healthcare delivery system. I mentioned before, we're a virtual first advanced primary care model. 90% of our care is virtual, with the majority of care actually delivered through asynchronous messaging on the Sutter Epic patient portal. Patients are attributed to a physician, a nurse practitioner, a registered dietitian that functions as a health coach, and they have virtual behavioral health access. Chronic condition management happens through the registered dietitian health coach and includes continuous glucose monitor support. The assigned care team does population health outreach to unengaged high-risk patients. So just to sort of set the context for that question. So specifically, some of the thoughts and examples that we have around improving access and equity in overlooked populations for a digital primary team, I think can focus on three key features, which I'll highlight today. So the first I'll say is digital onboarding material that's purposefully designed and personalized for that population. And I'll give an example there. Second is reimbursement and financial alignment for the primary care physician and supporting care team to communicate with the patient and their caregivers outside video visits. And then I would say the third is to have tools that enable integration with local physical clinic schedules. So the first around digital onboarding material purposely designed and personalized. When we got started, our patients needed to get onto the Sutter My Health Online app. And one of the things we noticed is that our Spanish-speaking population weren't utilizing that. And we actually stepped back and looked at the entire population at Sutter and found that there was this equity gap in accessing the patient portal. And in fact, when you compared English and Cantonese as primary speaking to Spanish as primary speaking, there was about a 50% difference. So about half the utilization. So in response, Sutter did an intervention where they took material, because this impacted more than just us here at Terra, but the entire population. So There's a material, Spanish-speaking material for onboarding and enrollment onto the app that was placed onto the website. And then there was also Spanish-speaking tech support created. So that's one example among many, many others. So the second point that I wanted to give around reimbursement and a financial alignment for primary care physicians to communicate with, communicate outside of video visits and to coordinate care with patients and their caregivers. So I want you to imagine, and again, this is an overlooked population that I've become much more passionate about addressing, is to imagine individuals that have physical and cognitive disabilities. They're homebound. They oftentimes have family members who are functioning as their caregivers, predominantly managing and supporting their care. So where I'll give you an example, this is a patient and subset of the population that we are seeing increasingly as we are bringing care into the, outside of the four walls of healthcare into the home. So you have a patient who has cognitive impairments. They're managing their non-driving, they're predominantly homebound. There's a daughter that's supporting her care. The daughter doesn't live near her mom, so she can't support to do that video visit, which is a billable encounter. There's a caregiver that might be also supporting, but they don't have access to the patient portal to be able to do that visit, on an app-based video platform. And so really what we turn to, and this was the beauty of the flexibility of model, is that we were able to do telephone visits and asynchronous messaging to coordinate their care. They could address things sort of real time. And that was really a win in preventing inappropriate utilization and really having a great experience for the patients. I would also say that it needed to be enabled also for the primary care provider, because that primary care provider needed to be involved for the complex problem solving and medication management. And so I would say in our capitated model, this worked for us. There was no financial disincentive for the primary care provider to provide those telephone visits and care with asynchronous messaging with the caregivers supporting this patient. So I think this is a big win for this overlooked population, and lots more that could expand there. The third piece is on tools that enable integration with local physical clinic schedule. So let's talk about the rural geography. So imagine individuals living in a functionally rural geographic area where there's a shortage of primary care providers. So one of the things we did is we partnered as a virtual only primary care with Santa Cruz, which is an area in Sutter that has had PCP shortages. One of the things we noticed that we had trouble getting Pap smears successfully scheduled and completed using the existing referral pathways. There's a lot of phone tag happening between the patient and the scheduler. So instead, what we did then the next implementation is we were able to get access to directly schedule those visits. And that was a big win. And in return, we were able to give the local primary care physicians and APCs time back for their in-person visits by managing their attributed patients with chronic conditions 100% virtually, and then giving them access to RD-led health coaching and CGM, continuous glucose monitoring support. So this really also helps to be successful in getting a long-standing subset of uncontrolled diabetes patients controlled. So those are the three things I want to highlight, I think, as ways that we've addressed overlooked populations. All right, thanks, Joe.
Of course, thank you, Yumi. It's really exciting to me in particular to hear you talk about value-based payment for primary care. I think one of the key learnings from COVID and sort of the larger crisis that primary care is facing right now is largely related to fee-for-service, right? Like the imperative to have to bring people in office to make sure that folks are paid. I mean, I think there's this really large sort of like an imperative in the environment to drive toward value-based payment in a way that provides consistency and sustainability and flexibility to these primary care providers so that they have a real future and they don't have to necessarily require at all times that folks come into their office in order to be paid, right? And I, at least at Blue Shield of California, I know that that's sort of one of our key beliefs in terms of like how we build a better and more sustainable future for primary care. So Brian, I know you also represent an organization that's doing really great work in this space, and you offer some products that are in some ways really tailored to meet the needs of specific populations. So I'd love to hear your perspective on that.
Sure, yeah. And just to give kind of context into who we are, so Included Health offers multiple solutions to provide every kind of healthcare for every kind of person is the goal. So we run the gamut of benefits navigation and administrative support for members through clinical navigation as well, providing things like online second opinions, high quality provider referrals, et cetera. and then as well as our virtual care offerings as well. We see that care integration is key to ensuring people have access to the right care at the right time. So all included care is what we call our integrated whole person offering that integrates our navigation wraparound services along with our virtual care services. As a company, we are very focused on elevating the standard of healthcare for everyone. And so in doing that, some of the ways that we kind of help address these inequities would include a few of our offerings. One of which is geared towards our LGBTQ+ community. So our community's offering is a group of dedicated care coordinators, and they're LGBTQ+ led and oversee healthcare navigation, provider matching, and support for our LGBTQ+ members. Many of that team themselves are part of the LGBTQ+ community and pride themselves on providing that advocacy to our members. Part of the work that they do means that we are maintaining a vetted directory of providers that are LGBTQ+ affirming and competent. These are providers who we can entrust our members to, knowing they'll get both high quality and affirming healthcare. In addition to that, internally, we have also a panel of vetted providers with expertise in the care of the LGBTQ+ population and can really help support things like PrEP and hormone therapy via our virtual platform within the scope of what's allowable within federal and state regulations. And lastly, like our LGBTQ+ community has developed partnerships to expand care. So including that with SCAN Health Plan, which is a plan to help support our LGBTQ+ seniors. So in a nutshell, that's kind of what we're doing with our LGBTQ+ community. I think another thing that I would highlight about our practice is in terms of helping remove barriers of geography or physical travel barriers, our virtual care practices are there to help support. So our virtual care practice provides not only everyday urgent care for routine and acute care types of needs, but we provide a lot of longitudinal care as well with our virtual primary care practice, and also our behavioral health practice that can support with both psychiatry and therapy needs. Make a point to have our clinical team broadly licensed so that we can increase provider access to members who are in areas where they might have a low density of available providers within a reasonable distance in time.
Great, thank you both. So it's very clear that there's a lot happening in this space and a lot of promise to these tools, right? I think that's what the discussion is focused on so far. But I do, again, want to sort of balance the reality of our current situation. So, what are the things that we need to keep in mind? Where are solutions maybe currently falling short on some of their goals? Where are the opportunities? What are some of the barriers to those opportunities? Any environmental or systemic factors that contribute to the dynamic, right? So, Gabriella, I recently read a report that you authored on this issue, and I know you'll talk about that throughout the day, but I would love to hear what you think about this.
Absolutely, Joe. And as I mentioned earlier, the Children's Partnership focuses on advocating for children from historically marginalized communities in California, and that also includes children of color who have disabilities or special health care needs. And in California, about 1.3 million children and youth under 18 have special health care needs. And about 71% of those children also identify as Latinx, Black, Asian American, Indigenous, or multiracial. Yet, despite making up such a substantial population of children with special health care needs, there really is such a limited amount of research and recommendations that center children with special health care needs from racialized communities and discuss how multiple forms of discrimination they experience, like racism and ableism, compound challenges that also impact their ability to succeed and their well-being. So when the pandemic started in 2020 and moving into 2021 and 2022, the Children's Partnership engaged in a research project that was really meant to center the experiences, knowledge, and recommendations of families of color who have children with a range of special health care needs in the development of a policy agenda around telehealth to help ensure that telehealth actually realizes its promise of increasing access to healthcare and health services. And we focus on telehealth because of its potential to address some of the barriers that children and families face in accessing healthcare, especially when schools and doctors' offices closed, two places where children with special healthcare needs had received most of their care. So we partnered with community-based organizations across California to recruit families of color in different regions whose children have special health care needs for listening sessions and also the completion of a survey. We use strategies to that sought to really share power with families and make this research meaningful and inclusive and adaptive to their needs and circumstances, which included paying families as experts and reviewing all draft learnings and recommendations with families and implementing their feedback before the brief was published. In total, we were able to recruit 85 families of color to participate in this community research project from 3 different regions in California, including Pomona, Tulare, and Riverside. And families self-identified themselves and their children as Latinx, Black, Indigenous, or Asian American, and multiracial. And over half of the families that we spoke to were also monolingual Spanish speakers. And before I go over what we learned were challenges, I'd also like to quickly highlight some bright spots and what we learned from families in terms of how telehealth made it easier for them to access healthcare services for their children. So families shared a couple of positive impacts of utilizing telehealth during the earlier parts of the pandemic. Parents from all 3 regions reported that their children had telehealth visits with a range of specialty providers, such as a gastroenterologist, an endocrinologist, a neurologist, and a geneticist. Telehealth was also used for counseling and speech therapy, as well as physical and occupational therapy. One parent reported that her daughter actually had telehealth visits twice a week with specialty providers. In our survey that all of the families took, most families, 61%, told us that they used their phone to connect to their child's provider offering telehealth, and less than a third of families used laptops for telehealth appointments. Another positive thing that we heard from families was that telehealth helped families address some of the challenges that they typically face when accessing care, like lack of transportation or childcare and long wait times for appointments. Families told us that it was a huge relief to them to not have to travel to an appointment, with some describing challenges around transportation, like not knowing how to drive, not having a car, or not having reliable public transportation and having to rely on pretty complicated and exhausting public transportation routes to travel long distances to see their children's specialty providers. Families also indicated a really strong interest in having the option of having telehealth for their children, while also noting at the same time that sometimes telehealth did not work to address their children's special health care needs. In our survey, nearly 1 in 2, 46% of families surveyed expressed that there were situations where they actually preferred in-person health appointments and wanted to have that choice. They talked about how for children who have certain conditions, some of the families were concerned that telehealth could cause confusion, delayed progress, or even harm. For example, one mother talked about the difficulty that she faces utilizing telehealth for her child who has epilepsy, where her child's episodes are triggered by too much light that might come from a device like a laptop. Another mother spoke about how her child has a speech development issue and how they struggled with telehealth, noting that the doctor, through their device, could not clearly see the child's mouth movements to determine whether the child was accurately using her muscles, and that the child similarly could not understand the doctor. But going back to your main question about the challenges that families faced, we heard 3 main long-standing systemic challenges that families experienced when they utilized telehealth during the earlier parts of the pandemic that really limited their ability to access care for their children utilizing telehealth. The first were digital barriers, the second were educational barriers, and the third were language barriers. So in terms of digital barriers, the digital divide really impacted families who have children with special health care needs and greatly limited their ability to benefit from utilizing telehealth. On our survey, more than 60% of parents experienced some sort of technological barrier to using telehealth. Families talked about the lack of not having the infrastructure needed that telehealth requires, including not having access to high-speed broadband or devices, One quote I want to share from a parent, just to give color to what I'm saying, is one parent said, "I live in a zone where Wi-Fi fails a lot, and the school has given us internet devices that are not that great. My daughter is in a program where she struggles a lot, and I don't have another source of internet because the companies tell me that they're not available in my location." And she's from a more rural area in Tulare. Second challenge that we heard from many families were around education barriers. And I was really happy to hear Yumi talking about some recommendations to address those kinds of challenges with the folks that she works with. But in terms of what we heard from families, in terms of education barriers that limited the opportunity of telehealth, there was just insufficient information, education, and tools provided to families around accessing healthcare services utilizing telehealth. And as we know, telehealth really relies on having access to the necessary technology to utilize it, but also the ability to understand how to use the devices, how to connect to high-speed broadband, how to use things like Zoom. And many parents in our listening sessions described not receiving any explanation or instruction on the structure of telehealth, the logistics that it requires, and how to use and how to actually access a telehealth visit. They didn't know what to expect before, during, or after a telehealth visit. And many felt like they could not adequately prepare for their children to be comfortable using technology to access care. Some families were even asked to do things like weigh their child or take their child's temperature during a telehealth visit, but the families lacked the tools to be able to do so, and then felt really bad for not being able to. One quote from a mother that I wanted to share was, she said, quote, "It was really difficult because I wasn't taught how to use computers or technology. My kids helped me, but it was really a challenge. My screen would freeze, my internet would drop because there were so many people using internet in my household at the same time." And then I finally wanted to mention a third challenge, which was language barriers. As I mentioned earlier, more than half of the families that participated in this research were non-English speaking families. And they noted facing many language barriers in utilizing telehealth, including difficulty accessing translated materials that explain telehealth, the telehealth visit, or what it was, and also not having access to interpreters and providers who speak their language. Over half, 52% of families on our survey reported experiencing language barriers in their telehealth visits, and over 1 in 3, 39% of families sometimes or were never provided an interpreter for a telehealth appointment when they needed one. Parents who did not speak English fluently, who participated in our listening sessions, emphasized repeatedly the difficulty they face in getting access to care and services in a language they and their children understand. And this wasn't specific to just telehealth appointments. It also was specific to their experiences in in-person appointments, but that challenge also was something that they experienced utilizing telehealth. And even with telehealth appointments, multiple families noted having to ask their neighbors or other family members or other siblings or other children to translate for them during health appointments because they could not access an interpreter, or it would take a very long time to actually access an interpreter for a telehealth appointment. Some families also reporting having to wait much longer for telehealth appointments when they requested interpretation services. Then they would have to wait for an interpreter in in-person appointments. For those families who actually had an interpreter during their telehealth visit, some actually reported mixed results in how well they felt the interpretation worked during a telehealth visit compared to an in-person visit, and sometimes mentioned things like they weren't actually sure whether or not the things that they were telling their provider were fully translated to the provider, and vice versa, whether the interpreter was translating fully what the provider was saying to the family member. And one family member came out with this really wonderful recommendation that we actually included in this brief. Was the family member actually recommended for there to be a written policy about how, if there is a telehealth appointment with an interpreter, and this should actually also be relevant to in-person appointments, but the family member said that if there's an interpreter in an appointment, that non-English speakers should be given more time for appointments because multiple people are speaking, and there is a need for more time. And family members would talk about how they would actually run out of time in their health appointments when there was an interpreter, and they weren't given more time. So we really think that was a very important recommendation that came directly from a mother as well. So those were the 3 challenges I wanted to mention. Thank you, Joe.
Thank you, Gabriella. I'm really grateful for your comments. To be candid, we have a lot of industry initiative events, and we haven't really focused quite as much, or really specifically on children or children of color or children of color with special needs. And I think your stories really highlight that we have a forum and we have a platform here to amplify those voices and amplify recommendations from advocacy organizations like yours, and that we should be doing more of that. So thank you so much for sharing that. And I think that's a really powerful reminder for us. Krishna, I'm so excited to have you on the panel today, as you know, and I do know Blue Shield is doing a ton of work in this space. So let's talk about what are the health plan's role, or what is the health plan's role in solving these issues that we've heard about today?
Yeah, of course. And thanks, Gabriel. I appreciate the reality check on the work ahead as well. We have, tons of, work ahead to sort of make this equitable, accessible, and sort of, as a modality that's available for people of all kinds. So thank you for the reminder as well. From a health plan perspective, Blue Shield actually answered this bell of sort of access and equity with our virtual Blue health benefits plan. So it's a relatively new offering where we are providing members with a care offering through a team of sort of virtual first primary, behavioral, and specialist healthcare professionals. In fact, we believe in it so much that we're offering sort of $0 sort of virtual visits as well. So we really want to, want people to use this offering more as well. And so as you all know, virtual care is a relatively new modality in the grand scheme of sort of a healthcare in our nation. Obviously, we had a big peak in the pandemic, and we think it certainly offered benefits and access to care in a different sort of manner. While there are barriers in the virtual care side as well, much like Gabriella has mentioned, we believe some of those sort of barriers are probably more solvable than the really complex, gnarly problems we've tried to deal with it as a state, as a nation, whether it's housing insecurity and transportation issues, or trying to match sort of members with the right kind of physicians who understand them or really understand their sort of nuanced intersectional identities there. But that work is still ahead, right? It's still sort of early, I'd say, as a care modality, and so we need to study and see if this is really meeting sort of the needs at the moment and needs of the members as well. What we do like about Virtual Blue is just that sort of access to care in sort of non-traditional hours, non-traditional ways. So it's not just care in Friday, sort of an 8 to 5 type thing. Obviously, being able to provide access to care at all hours of the day. I think what I said about that. We also think it gives our members a chance to sort of pick a primary care doctor based on sort of criteria they may sort of select as well, whether it's sort of language, whether it's gender identity, sexual orientation, race, ethnicity. We think it gives just the power of data to get more nuanced sort of matching algorithms as well. So we're excited about that as well. And then we really think opening up the aperture on sort of the geography, being able to form a broader statewide or multi-state connection, I think with another big benefit as well. So we are excited with the work we've done, but of course more work ahead. Of course, we like the fact that we can we've seen time and time again that if members and patients have a relationship with the doctor and can create sort of a longitudinal history, it creates sort of a value-based sort of care offering, a relationship, as well as just care that is high quality, accessible, efficient, affordable as well. So, but we want to sort of test that in the virtual type modality. And certainly our hope is that virtual care can deliver care that is sort of as good or better than in-person care, and that's of course a hypothesis we'll need to actually test as we get more members and more data as well. So I know Yumi will have to stay close to your work as well and see how that's sort of playing out. Impressive results, of course, with the high quality engagement and sort of total cost of care reduction as well. That said, certainly more barriers as well, right? Like particularly as I think about barriers for our sort of BIPOC communities, the tools and the skills to navigate. I think Gabriella, you raised some of the issues on educating the flow of the visit is going to be important. being able to access smartphones, which I know are more accessible these days. I was studying some surveys results from the California Healthcare Foundation. Surprisingly, I was expecting to see more barriers related to smartphone access, but that actually didn't bubble up. It's mostly on video audio glitches than actually not having a device, which I was pleasantly surprised with. But that said, I think there is opportunities for access to smartphones, certainly support with sort of downloading the apps, understanding the flow of the telehealth visit, certainly spotty access and limited internet access. Gabrielle, you brought that up as well. So continue to sort of double down on ways by which we can create more broadband access, and of course, more cell coverage as well. It will be critical. Language barriers came up in our sort of studies as well, whether it's both oral, written, access to translators, timely, so that piece is there. I think there's also sort of a fundamental hesitancy and trust with sort of that sort of talking to a computer and like who's on the other side. And I think we'll need to overcome that as a healthcare system, I feel. And we've also seen feedback on just privacy. People aren't always in spaces where they can have open conversations, especially if they're in a shared living situation. I think those have also come up, and we'll need to figure out ways by which we can sort of do that. And certainly some of the broader, just like tech support, like how do I get access to people and technology can sort of help me troubleshoot the sort of glitches that happen as well. But yeah, those are, I'd say, some of the barriers, definitely areas for us to, keep solving and keep moving forward as well. Definitely, I think the promise of it, weights higher than the barriers, but a good reminder for us to keep at the barriers as well to continue to solve for them.
It's really interesting to me that, each of you represent pretty different parts of the sort of healthcare ecosystem, right? But you all sort of see some same barriers, opportunities, really a lot of common themes between all of your comments. And it's really interesting to me to see all of those sort of come together in sort of a cohesive narrative about what needs to come next. So that leads me to the next question. And I'd like to ask each of you to reflect on, again, your own experiences, but what you've heard and what you've learned today from each other. What do you think is the most critical next step that we could take to help realize this promise of virtual care that we talk about, right? Like, again, focusing on improved access and equity. So who needs to be involved? What specific actions should they take to drive progress? And I asked this question in particular to help our audience understand, again, that beginning comment, which is really what's their role and what can they do here? So Yumi, why don't you kick us off?
Thanks, Joe. Yes, no, it's really great to hear some common themes, and specifically to see this Virtual Blue PPO product that has some capitation, it sounds like, in it. I would say, I think the critical next step that sort of ties together the themes and what we've learned is that financial alignment for primary care to deliver more than just video visits as a virtual offering. So really being able to do asynchronous messaging, telephone visits as well. And then I would say the other component to that is to be able to do that proactive outreach if we want to address those overlooked populations. I would focus on, as I mentioned, the telephone and asynchronous messaging, and perhaps even synchronous considerations for synchronous messaging with other care team members as well. I would also focus on that financial and real alignment or reimbursement for primary care providers to do panel management, or what I call engagement management. If we want to be successful in reaching these overlooked vulnerable populations, or specifically populations that are just not engaging with healthcare, we need to be purposeful in our outreach. We need to make those interactions frictionless with a clinician that they trust. And we need to create the time and compensation for those clinicians to do the outreach. So to do the outreach, to be able to right-size their care. I think I really see primary care as shackled in our current, financial alignment. So I think if we really want to unleash the potential for relationship building using technology to do that, and to engage the unengaged patients, to give time for clinicians to have thoughtful and meaningful discussions over kind of longitudinal care. That's the alignment that we need to make. And then, so I also want to just answer the question around who should be involved. So making sure patients are at that table, because they need to have feedback. As you can see, I have seen this when it doesn't happen, where you need to get feedback from patients that those implemented digital pathways did not have the unintended consequence of actually creating more barriers to getting their clinical issue addressed. And instead, it created this one-touch resolution. Frontline providers need to also be at that table to make sure that the implemented digital pathways facilitate their time in flexible, right-sized care rather than this one-size-fits-all service offering. And then health plan payers, Blue's ahead of the curve. You're doing that. You're designing a health plan product that's not just a fee-for-service system with video visits bolted on, but it's a health plan contract that's financially aligned with modern clinical workflows that enable care outside of traditional billable visits. And also consider, and I'll throw this out there for Blue Shield, consider ways that we can do data sharing through other means than claims data. So using things like EHR data sets, right, as a way to information share, and also just to cut down this, ongoing need to do these traditional build encounters to share data. All right.
I appreciate those comments in particular because, if I'm going to if I could add a call to action there, I think there's really an opportunity for health plans to come together and really think about how we do this in a collective way, right? So I heard from you that health plans really need to have some degree of financial alignment in that contract with providers in a way that incentivizes the right behaviors. But particularly in a state like California, where the insurance market is relatively competitive, and that is a good thing, I might add. It does mean that the power or the impact of any one health plan going out there trying to do something alone is relatively limited. So I think there is an imperative, not just in California, but across the country, for health plans to work together and meaningfully try to align these incentives, right? I mean, that's something that we're trying to do at Blue Shield of California. So just a brief call out for the California Advanced Primary Care Initiative that is being run by the California Quality Collaborative and Integrated Healthcare Association. They are working together to do this. We are part of that initiative. It's really about how we align incentives for primary care in a way that, again, creates that more sustainable future for primary care that we all see. So I just want to add that call to action to any health plans listening here. There is an opportunity to work together and work with your purchasers, right? The purchasers go even one step farther upstream. That's where a lot of the money is coming from. So purchasers as well, if you're an employer, you have an opportunity here to also work with your health plans through your own contracts to try to really drive that alignment all the way across from your level at the purchaser all the way down to the patient level. It has an impact. So moving on, Gabriella, would love to hear your thoughts on this. Like, what are these specific actions that folks in the environment need to take?
Absolutely. Thanks, Joe. And the recommendations that I'll talk about now are really state level systemic recommendations that try and address the three challenges that I mentioned earlier in the previous question. And they're all targeting different policymakers in California, including the California Department of Healthcare Services, the California Department of Education, and the California Legislature. So for our first set of recommendations, these are really aimed at the California Department of Healthcare Services. The first one is around the new community health worker preventive services benefit in Medi-Cal. We're very excited about this new benefit and its potential to advance health equity for children enrolled in Medi-Cal. And we're very excited specifically about the fact that community health workers will be able to provide preventive services, including education, outreach and navigation services for families utilizing telehealth as part of this new benefit. But our recommendation here is really, we think that another service that should be explicitly covered is when a community health worker works with a child or a family's medical team to help that family navigate telehealth itself. So we think that the Department of Healthcare Services should clarify that community health worker services that support Medi-Cal members in effectively utilizing telehealth to access healthcare are also considered preventive services and covered under that new benefit. Our second recommendation to the California Department of Healthcare Services is really around language access. And these recommendations are meant to increase language access in Medi-Cal. when families have telehealth appointments. The first is we think that the California Department of Healthcare Services should create guidelines around reasonable time periods to receive an interpreter once requested for telehealth and in-person appointments. The second is DHCS should also clarify that telehealth appointments that include an interpreter should by default be scheduled for longer than if the same appointment were being scheduled without an interpreter. And then finally, we are urging the Department of Healthcare Services to clarify that Medi-Cal managed care plans have the responsibility to provide all telehealth related documentation in threshold languages. Our second recommendation is really focused actually on the California Department of Education. A couple of years ago, the Children's Partnership was sponsoring a piece of legislation called AB 2315, which was successful and codified into law, and essentially it requires the California Department of Education to work with the California Department of Healthcare Services to create guidelines for schools on utilizing and how they can utilize telehealth on school campuses to increase access to mental health services on school campuses. So this year, we're really urging CDE, and CDE has started a process to finally create those guidelines because we really think it would be an incredible opportunity for more schools to have telehealth available on school campuses because schools already have the technology that children need to utilize telehealth appointments. So we're really hoping that CDE publishes those guidelines to support schools who want to do that this year. And then finally, we also have a set of recommendations around current pieces of legislation that are going through our legislative process right now in California. You can find all of those bills listed actually in a new policy brief that we recently published that's specifically focused on digital equity and how it shapes child health and well-being. But one of the bills that I wanted to mention now that there's a current opportunity to support is a bill, AB 41, the Digital Equity and Video Franchising Act, that's authored by Assemblymember Holden, which would create greater accountability for cable broadband providers who perpetuate digital redlining and improve affordability and service for customers through enhanced public oversight and stronger anti-discrimination standards. And if it hasn't been shared already, I can share the draft template letter of support that folks can use if they'd like to send in a letter of support for this bill. Thank you, Robbie, for sharing it.
Yeah, thank you, Robbie. Indeed, Robbie's our backup house support. Thank you, Robbie, as always. I really appreciate your comments, Gabriella. I think, one of the key themes that I've heard come out a lot is the way that we need to leverage some of these trusted community supports, whether it's a community health worker or a school, right? Like a place that a child is regularly attending, to really advance as a sort of core strategy to increase access, but also improve equity, right? And I love that you really brought in, again, the Department of Education. I think that highlights the need for multi-stakeholder and, multi-sector partnerships to drive this work forward. So appreciate those comments. Krishna, you're next.
I guess my reflection is probably more fundamental. I think to truly match sort of care with people that need it and sort of match the physicians and providers to people with sort of different kind of needs, I think being able to truly like ingest the sort of a self-identified data, whether it's like language, whether it's race, ethnicity, gender identity, sexual orientation. I think those being able to collect the data that people are willing to sort of like share and identify in a way that we can actually use to sort of stratify and then match, whether it's from members or from providers, so that we can do a better job of sort of matching the sort of the need as well as the availability, I think is key. So I think where we can spend time sort of building some of the sort of pipes and foundation elements, I think will go a long way to make sure we can do the right matching as well. So and the other one was sort of the intangible one, the sort of the trust that I mentioned earlier on as well, which is, I know it's of course a long tail sort of work there as well. How do we sort of improve the trust in our sort of broader healthcare experience, the healthcare system as such, but particularly for people that are sort of marginalized, and sort of look at the healthcare delivery system or the healthcare system as a whole with sort of a mistrust, and how do we sort of raise that sort of trust level as well so that people get more comfortable. I think it's two sort of reflections.
Thanks, Krishna. On that data piece, I know Industry Initiatives has done some work and some publications in particular on the sort of the role of social determinants of health data and its role in improving equity. So I don't know if our Backpass team has that link immediately available, but if possible, would love to see that dropped in the chat for our audience as well. Brian, you want to take us home on this one?
Sure, yeah. And I'm going to jump onto the theme of data, I think, as well. I think to really realize the promise of virtual care, what I see a need for and what we're focused on is trying to improve integration between our virtual telehealth platforms and with the physical brick and mortar type of healthcare and our health systems. I think right now, telehealth as a standalone won't really work in the future all by itself. And the best experience really is that a member has like one place to go to get guidance on where to go, and that they have a seamless transition into whatever type of care that they're needed. To do that though, like we're going to need to be much more deeply integrated across organizations and between payers as well. And I think one other kind of like logistical consideration would be that we have seen that telemedicine has been a major benefit at closing some of these geographical care gaps. So this is really, really helpful to have providers practicing across state lines. We do need, I think, a better or more streamlined way of supporting those professionals and getting licensing and credentialing. Our existing system is not really designed with the intent to help facilitate practice across state lines.
I think that was a huge learning from COVID, right? I think that was a big theme that came out in terms of like a barrier to immediately scaling. A lot of the virtual solutions that were available to us was, how do we address this core fundamental issue that exists in healthcare, and exists for good reason, of course, but it was a barrier, and it's one thing that we learned. So we only have, like, very quickly, we do have a question from the audience that I would love to ask. So how do you ensure that patient portals are accessible to people with disabilities? For example, are the patient portals accessible to visually impaired users who use speaking browsers? Yumi or Brian, do either of you want to take that?
Brian, I can jump in. I was just getting ready. I was like texting and responding to that. It's such a great question. I think we very much, we're using Sutter's, patient portal, Epic, MyChart, my Health Online patient portal. I'm kind of embarrassed. I actually don't know the answer to that question, but I'm sure that the system would be, taking into consideration some of those, the accessibility. I think that historically, what we have done for those that are visually impaired is to do video visits or whatever their kind of their audio only option is. And then in terms of the question for the sign language interpreters, closed caption technology, hard of hearing, I haven't seen in our integrated video system that there's a closed caption option. I haven't noticed that. I know recently they did integrate interpretive services. I'm not sure if that includes sign language, but certainly other languages. So I know the system is working on, advancing that. I think my commentary is just that that's a pretty, I would imagine that, thinking through this from an informatics perspective is a pretty heavy lift. And so I just wonder how, we're integrating this huge delivery system, right? How are places across the country doing this, right? Smaller places. So I'll pause there.
Any of our other panelists care to chime in on this one?
I would just comment that this is a huge area of opportunity for improvement in our tools, for sure. So if it's a straightforward telehealth visit via video, that's one thing. But once you add in the element of needing either translation or assistance with visual or hearing impairment, there is this kind of three-way connection that I don't think many places have a solution for as of yet, and it's a big area of need that you've highlighted. I wish I had like a better answer for what to do next, but I think that technology gap is what needs to be filled.
Well, I think that is a good note to end on, because it highlights the need for partnership, right, and collaboration across the environment to collectively address some of these very real and very, very known issues that that need to be addressed for these populations. So we've got about a minute and a half left, so I think I'm going to call it. I am so thankful to all of my panelists here today and all of you in the audience for joining us. I personally feel immensely privileged to host these conversations with folks like these. You know, again, it's really so interesting that people come from, you know, different and diverse parts of the environments, but we still have some of these common themes and learnings to break forward. So again, thank you. As a reminder, we will send out a recording to all of those registered. So please make sure you're signed up for the event with your email if you haven't yet, or if it was forwarded to you, please do so. We will also send the recording to our distribution list, as well as notices for all of our future events. So please do sign up for that on the Industry Initiatives website. If somebody from our backend team could drop that in the chat. You can just go straight to our website. The distribution list sign up is right there. Again, you'll if you sign up for that, you can stay in touch. We send out quarterly newsletters. We have a lot of great content that we push out through there. So make sure you stay in touch with us and catch all the content that we have coming forward. So I hope you all have a wonderful afternoon. Thank you again so much. See you all later.